So today we are going to look at how to prepare to aid the QE1 exam, because a lot of candidates have a lot of questions, and we're going to go through some important, links on the website to know how best we can prepare for this exam. So I'm just going to share my screen. So for me, I have a principle in MedCognito that if we're going to do well in the exam, we've got to have a good approach to the QE1 exam in general, a very good approach, okay? And number two, we've got to use the right resources. And the right resources are already outlined by the Medical Council of Canada. And we've got to also use the right strategies to study. And that is exactly what we're going to do today, so that we can get the best out of this particular presentation. By the way, someone may ask, what is the Q1 exam all about? Because one thing I've also realized is, and I'll be showing you some statistics. You have, most of the time, the international medical graduates who are taking this exam, a lot of the international medical graduates are specialists. Some are already practicing doctors from their country. And at times, because of the nature of the exam, we've taken over and over and over again, like various exams we've taken from our various countries, we are a bit confused about the nature of the exam. This exam is very simple. It is an exam at the end of medical school in Canada. So before medical students get into residency, this is the exam they take. So just remember, when you were in medical school, when you finished medical school, just ask yourself, what was the level of your knowledge? This is where the main issue is, because a lot of candidates usually confuse, they think it's a specialist exam, and because of that, it also affects the way they learn for the exam. It is an exam focusing on basic and core principles. And today, I will show you all the objectives you need to master for the exam. I'll just show it to you, because it is not a hidden thing. It is something the Medical Council of Canada wants you to know. And it is not an exam where you should be considering highfalutin stuff. No, it is wrong. It is not an exam for highfalutin stuff. It's an exam for very simple, basic things. And that is why I've put it here that keep it simple. It's an exam which, if you keep it simple, you can easily ace. But if you make it complex, it becomes complex as well. Now, what do I mean by that? One thing a lot of candidates have been crying over is the issue of time management. Time management. The exam has two components. There is the morning session and the afternoon session. The morning session usually goes for about 3.5 to 4 hours. And it has 210 multiple choice questions. So when I sat down to do the calculation, it looks like you have about 1 minute, 10 seconds for each question. So that is very critical. Like, if it is 1 minute, 10 seconds for each question, you've got to ask yourself, hey, how am I going to make sure that I navigate this to get through everything? Some candidates are good enough, like they know their concepts. However, they are not fast. And because of that, by the time they get to, 180, questions have already beaten them. What strategies are you going to use? These are things we try to emphasize on, when we are preparing candidates for the exam. Because as soon as you start spending about 2 minutes on a question, that is dangerous. That is not good. Then in the afternoon, it is 3.5 hours for 38 CDMs. Usually the CDMs are STEM questions. So you may have one question and it will have maybe 2 or 3 questions underneath, or it could even just be one question. And the CDM has mainly 2 components. The first component is you typing in your answers, and the other component is you choosing among a lot of questions or a lot of answers, maybe the correct one, okay? But the interesting thing is that in April 2025, please write it down. In April 2025, the format is changing. They are scrapping the CDM exam and they are making it only MCQs. And we've realized that the MCQs is where a lot of candidates also have a lot of problems. not because they don't know the concepts, but because they are not able to manage time well. So you realize that if you are taking this exam for almost 7 hours, you're going to be thinking very, very fast within a 7-hour period. That is what, from 2025 April, that's what is going to happen. So if you are planning on writing your exam in 2025, please know very well that from April 2025, the format of the exam is going to change. It's going to change. It's going to be MCQs in the morning, MCQs in the afternoon. All right. So please, if there's anything you need to work on, it will be that you need to work on your time management, because the exam format is going to change. So what methods are we using, or how are you going to deal with time management? Because time management is a big problem. How are you going to deal with time management as your problem? Number one. So how are we going to manage the time and get through this so that we are not caught with the issue of time management? Number one, either through brute preparation. When I say brute preparation, it's like, just the way we learned in medical school, going brute and just making sure that time does not catch us, like the way this guy is running away from the time. Or, continuous recitation of facts so that you are familiar with them. And we also have a whole portal in MedCognito where we are, after all that you've learned, we call them med bullets. We also have, recitation of common facts you must know for the exam, okay? And then being sure of your prep guide and your materials. And for me, that is the solution. When you are sure that every MCCQE1 objective is cleared, then you know that you're on the right path. And I'm going to show you the MCCQE1 objectives you need to review before your exam. Number two, the next tip we need to focus on is spending time and energy on what is important. At times when I'm talking to a lot of candidates, they tell me, oh, Dr. Bruni, I've read through the whole of Toronto Notes. I go like, really? No, don't do that. If you are spending your time reading through the whole of Toronto Notes, know very well that you are using a wrong approach. There's nothing wrong with Toronto Notes. There's nothing wrong with Master the Boards. But these are resource books. These books don't tell you exactly what you need to cover. There are a lot of things in Toronto Notes which are not necessary for your exam. That's what I'm trying to say. So rather than just reading through Toronto Notes, hoping that you've reviewed your exam, why not rather focus on the things which are necessary to be covered so that you can go into Toronto Notes to review them? So I'm going to stop sharing my screen and I'm going to go with you to the MCC objectives. I will drop the link in the comment section. And for those on Facebook as well, I will drop the link as well so that we will take our time. The MCC objectives are broken from A to Z. Okay, I'm going to, let me copy the link and put in the comment section right away. So if you are preparing for the exam and you've not covered these topics, use today and the next few days to make sure that you've reviewed them. Usually there is another page which talks about the MCCQE1 objectives. Let me just show you something here. MCCQE1 objective 001. That it is difficult to navigate that, okay? It is difficult to navigate that. I'm just going to look for that for you. I'm just going to look for that objective abdominal distension. Okay, good. So a lot of people navigate the system. I'm just teaching you the various ways people navigate the system. So a lot of people will start from objective 1, and then they'll just click, and then move on from objective 1 to the next objective, right? Like this one. But for me, if there is the group of MCC objectives to focus on, it is this one rather. It is the one which is talking about the medical expert, all right? The one which is talking about the medical expert. So for example, if you are studying for your exam, I want you to make sure you've mastered abdominal distension, which is going to talk about ascites. It's also going to deal with things like intestinal obstruction. In fact, if you open that objective, it's going to tell you, you have to also make sure that under A, you've mastered abdominal masses and pelvic masses. You've also mastered abdominal pain. The abdominal pain, you've got to master abdominal pain in children, abdominal pain in adults. acute abdominal pain, chronic abdominal pain. And acute abdominal pain, you want to master abdominal pain causes which can kill the patient, and those which are not necessarily life-threatening in the immediate sense. So if you're able to manage and understand abdominal pain causes which can kill a patient, if you are asked the question in, say, the CDM about a patient who has come to the ER with abdominal pain, sudden onset abdominal pain, what are your differentials? You are going to list those ones. Then you also have to master abnormal heart sounds and murmurs and abnormal liver function tests. We've reviewed all these things, and abnormal serum lipids, acid-base abnormalities, allergic reactions. So all of these are in the link I've put in your comment section in the Zoom link. Please take your time and review them. If you want to ace the exam, this is where the exam questions are set from. That's the truth. The exam questions are set based on these objectives. You know, the Medical Council of Canada is very straightforward, and they'll tell you that this is what you have to study for the exam. Don't go reading any highfalutin stuff. So let's come to maybe L. If you're learning language and speech disorders, so we are learning things like autism spectrum disorder, the legal and ethical organizational aspects of medicine, the limp in children, okay? You also have to, review limp in children. What are the causes of limp in children which can cause avascular necrosis? What are the causes of limp in children? So these are all things you need to master. Lymphadenopathy, lump and masses, okay? Then you just go down. When you come to M, you need to master menopause. You need to master menstrual cycle. You need to master mental status and altered mental status. So what is going to be your approach to a patient with coma? What's going to be your approach to the patient with delirium? What's going to be your approach with a patient with major neurocognitive disorders like dementia? What's the difference between dementia and delirium? So, for example, if you notice that in your notes, I am hitting on delirium and dementia, it's not because of anything. It is just because it's in the objectives. Take disorders, movement disorders, chorioathetoid movements. Then when it comes to O, we have obsessive compulsive related disorders, pain. So you realize that even in those who took the sprint course, we reviewed the pain ladder, how to manage pain from acetaminophen to opioids. All right. Then you go to palpitations, where you're going to deal with arrhythmias, you're going to deal with AFib, especially, you're going to deal with, VFib, all those things which cause palpitations. When are you going to request TSH? When are you going to request ECGs? And then we have pediatric emergencies, like in an acutely ill patient. If you go to the pediatric notes, it is there. Your approach to a hypotonic child, your approach to a fastened child. When are you going to rule out life-threatening conditions like meningitis? When are you going to rule out conditions like otitis media and all those things? So please, that link I've put in the comment section, take it very, very seriously, because that is where everything is. That is where everything is. If you're able to master that, you're good. Seriously, if you're able to master, if you're able to master that particular thing I'm talking about, these particular objectives, if you don't take anything from this conversation at all, take this, please. Master these objectives. If I were you, I would download it, write it down, put it on my bed and just master them. If you're able to review all these objectives, you are good for the exam. This is what the exam is based on. So I think now you understand why a lot of candidates go in and they'll tell you, like, I've read the whole of Toronto notes, but I don't know what happened. Yes, because they are not focusing on the objectives. All right, good. So now, after you've reviewed objectives, you also have to review something very important. We call it the MCC blueprint. The MCC blueprint. The MCC blueprint, it helps you to put things into perspective, because there are dimensions of care. And the dimensions of care cover the spectrum of medical care. And it also reflects the doctor's scope of practice and behaviors. All right. So we are going to look at it. So, for example, this tells you about which areas in the exam your examiner is going to put emphasis on. So let's say health, promotion, and illness. That is what people will put as public health, but it's not just public health. Because public health and biostatistics is one part, but you also have things like screening. So that's why you realize that colon cancer screening, pap test screening, breast cancer screening with mammogram. When are you going to do mammogram? Will you screen people for prostate cancer? At what age will you start screening people for diabetes? Which people will you start screening earlier for diabetes? It all falls under health promotion and illness prevention. But then you realize that that is 20 plus 5. So the weight of that is not as much as acute care. So acute care is what we basically will talk about, emergency medicine.
Working in progress.
That's what you realize, that we're talking about things like emergency medicine. We're talking about, you are in rural Saskatchewan, a patient is brought to you with chest pain. So you realize that they put a lot of emphasis on that. As well as chronic conditions. But in all this, if you look at the weights they put there, the acute conditions carry more than chronic conditions. Chronic conditions can be diabetes management, things like hypertension management, things like patients with inflammatory bowel disease. Why? Because you may have to do spaced colonoscopies for the risk of rectal cancer. Okay, so you have all these. So first, if I were you, after I've learned the MCC, after I know the MCC objectives, I'll go through the MCC objectives and find out which ones are emergency medicine topics that I need to master, and then which ones are, chronic conditions that I need to master. And then I'll come to the health promotion. So all the health promotion, pap test, colonoscopy, all those things, mammogram, TSH. Do I do TSH in everybody? Do I screen for vitamin D in everybody? Those kinds of things. Now, that is the systems. But this is how the MCC looks at them. It looks at them in terms of dimensions of care. Then, if you come to the right side here, you realize that the physician activity, which takes majority of, or which the exam is heavy on, is the assessment and diagnosis. So, for example, how do you diagnose a patient with diabetes? How do you diagnose a patient with Conn's syndrome? How do you diagnose a patient with hyperthyroidism? Because the weight there is 45 plus 5. And then management. Because if you're able to focus more on assessment, diagnosis plus management, you realize that the issue with communication, under communication, that is where ethical issues come in. Do you tell the patient or you don't tell the patient? Which patient will you inform the mother and which patient will you not inform the mother? Which patient is an emancipated minor and which one is not an emancipated minor? So if I were you, I will use this blueprint. I'll take a screenshot of this. It's also on the MCC's website. And I'll use it as a guide. So that whatever I'm studying, I ask myself, can I assess? So if somebody comes in with chest pain, can I assess and make a diagnosis of the various causes of chest pain? Because chest pain is an objective. Can I manage the various causes of chest pain? How do I communicate? Like, what's the time interval I need to communicate a patient who has myocardial infarction as compared to a patient who has costochondritis? They are both chest pain, but one will kill the patient if I don't manage it properly, and the other one, I can manage it over days. Okay, and then professional behaviors, that is ethics. Okay, so professional behaviors, that is ethics. So you have to understand professional behaviors in health promotion. So ethical issues in health promotion, ethical issues in an acute state. That is why I can ask you a question, say a patient is involved in motor vehicle accident, the patient is brain dead. Where is it meeting? It is when acute cases meet professional behaviors. What is your next step in relation to communication to the family? That is why I can ask you chronic and professional behaviors. I can have a patient with HIV, and I'll ask you that, for example, what is my obligation Do I tell public health? It falls here, chronic behavior and professional behaviors. And then you also have psychosocial aspects and professional behaviors. For example, a patient who has depression, who is planning on homicidal and suicidal thoughts. What do you do? What's your obligation as a physician? But you realize that the weight here is 15.5 plus 10.5. But if I'm looking at something like a patient with chest pain, 35.5 plus 10.5. So I have to focus more on communication in acute settings as compared to communication in professional and aspects of behavior. But they are all important. I'm just telling you the way you have to rank them when you are studying. That's all. But you've got to review all of them. So it's the same thing I'm just going through here. And I don't want to bug you with all that. So I've already talked to you about the MCC objectives. I've already sent you the link to the MCC objectives. After this conversation, I'm going to put it in the Facebook group as well, so you can have it there, okay? And they are all based on the CanMEDS rule. So when you are learning as well, so we've learned the MCC objectives, we've learned the dimensions of care. Now, the last thing you have to learn, which will make everything complete, is the CanMEDS rules. The CanMEDS rules are looking at you as a physician, as a medical expert. But remember that I told you that the objectives you are learning, most of them are focusing on the physician as a medical expert. Because as a medical expert, communication comes in, professionalism comes in, that is ethics, scholarship comes in, that is diagnosis and management, health advocates comes in as a leader. So maybe if you're a doctor, managing a patient and you have a resident with you, what are your obligations towards the resident? And collaborator, in which cases are you going to refer to other specialists? In which cases are you going to get other healthcare professionals to come in? So which CanMEDS roles should you focus on? This is the framework you need to use in your preparation for the exam. That's all. Any question?
The management of time.
What?
The management of time strategy, please.
Management of time. So, as I said, the management of time, you can only manage time in two ways. Number one, if you know your material so well. And number two, if you know very well that I'm not spending more than 1 minute, 10 seconds on a question, especially in the MCQs. Most of the time for the afternoon paper, a lot of candidates, at times are able to finish and they have like 30 minutes to spare or 1 hour to spare. The main problem is the morning, because that one is intense. 210 questions. You have to know, and move on. So the main thing is you have to make sure that you know your material so well. You've got to make sure that you know your material so well, so that when you get into the exam, that is not a time you're now going to start thinking, hey, what am I doing? What am I doing? No. So with the management of time, that is the main thing I can say. Brute repetition of the MCC objectives, just reviewing them. So someone said, after reviewing the objectives, where should you go? Sure. If you want to go to Toronto Notes, that's fine. You can also go to Up to Date as well, because Up to Date is the MCC's suggested resource. You can go to Up to Date, or there's another resource called Dynamed. Maybe when we are done, I'll just show you the link. It's called Dynamed, okay? Dynamed has a lot of the information like Up to Date as well. So time management, brute repetition of the MCC objectives, making your notes and just going through it. And then the resources, you can use Toronto Notes, but make sure that every topic you're reading in Toronto Notes is in the MCC objectives. Make sure that every topic you're reading in Master the Boards is in the MCC objectives. If it's not in the MCC objective, forget about it and move on. So how are you going to map the MCC objectives with like the various cases? For example, if you're using diabetes as an example, diabetes objective 37.2, okay? So let's look at this. Diabetes. Where will diabetes fall? Number one, under health promotion and illness prevention, diabetes will fall there. So under health promotion, where will diabetes fall? Diabetes will fall under you encouraging the patient to exercise, you encouraging the patient to eat healthy, you encourage the patient to follow the Canada Food Guide. When it comes to diabetes under acute, then you're looking at management of diabetic complications. For example, hypoglycemia. Number 2, diabetic ketoacidosis. Number 3, non-ketotic, non-acidotic coma. Okay. Number 4, if you come to chronic, you are looking at complications of diabetes, long-term complications of diabetes, like macrovascular and microvascular complications. So, for example, you can look at, diabetic retinopathy. You can look at diabetic nephropathy. You can look at, how diabetes can affect the heart. You can look at all these things. Then you can even go to the psychosocial aspects. How does diabetes affect a patient's mental health? So if a patient is diagnosed with, poorly controlled diabetes, it can even lead to some forms of depression and all that. Now, with all these things you talked about, you're going to learn how to manage them. So how are you going to manage the patient with hypoglycemia? How are you going to manage the patient with ketoacidosis? Okay. How are you going to manage the patient with all the complications of diabetes? That's what you want to focus on. So using diabetes alone, you can map up the various things. Under what circumstances will you want to communicate, and what professional obligation do you have towards a patient with diabetes, probably who has been having recurrent episodes of hypoglycemia, and the patient drives a truck? You may want to let the driving licensing unit in your province know about it, because this patient may be a high-risk patient on the road, right? So you realize that diabetes is not diabetes alone. If you look at it in the context of the dimensions of care and efficient activities, assessment and diagnosis, you have to learn how to diagnose diabetes, how to diagnose hypoglycemia, how to diagnose diabetic ketoacidosis. All right. How are you going to manage a patient with hypoglycemia, ketoacidosis? How are you going to communicate with the patient? If the patient is comatose, what's your obligation? If the patient is conscious, how are you going to manage the patient? And what are your professional behaviors as well? So that is basically that. So, for example, I broke it down that under diabetes alone, if there are questions, what are the questions to expect? Under assessment and diagnosing, health promotion and illness prevention, your questions you have to think about should focus on screening for diabetes. And you have to look at diabetes in children, diabetes in adults, diabetes in pregnancy. Which test do we use in diagnosing diabetes in pregnancy? Do we use the 50-gram glucose test, or do we use the 75 grams? When do we use the 50? When do we use the 75? And what values should you know about the 50? What values should you know about the 75-gram one? And when you get under management of acute conditions, a question should focus on initial management of a patient presenting with diabetic ketoacidosis. And you realize that in the management of diabetic ketoacidosis, you have to tell yourself that I'm not going to give insulin until I know the patient's potassium level. These are the things, these are the tricks you need to know for your exam. And under communication and psychosocial aspects, question could focus on counseling a patient who is unable to afford their medications and testing supplies. What do you do? What are the resources in the community which the patient can depend on? So the truth is that not every objective, not every MCC objective will map to all the categories of the blueprint, and that is fine. For example, if you get to the legal and ethical aspects, it's not everything will map under the MCC objectives. So you just have to know that, okay, this thing I'm learning, what focus am I going to put on? Number 3, someone asked the question about how to manage time. Another important thing you need to focus on, so far as time management is concerned, is by doing a lot of practice tests. A lot of practice tests. And when I say a lot of the practice tests, the Medical Council of Canada has its own set of questions, which they've made available to the public. You just have to pay. It's like a subscription. You just have to pay and then try those questions. I tell everybody in our course to do those questions. Everybody in our course should do those questions, because it will help you to appreciate, the exam you are going into very well. The interface looks like the exam portal, and everything you need in there is similar to the exam. The the way the computer screen is designed and everything. So please, if you are preparing for the exam, I will suggest spend money and subscribe to the Medical Council of Canada's mock exams. Very, very important. All right. Okay. So how will you be scored and what should you watch out for? Questions have their individual scores and they have their level of difficulty. And I always tell candidates, if you go into the exam and you are getting easy questions, be careful. Number one. Number two, if you go into the exam and you get questions surrounding the same thing, be careful. For example, chest pain, and then maybe 2 questions down the line, chest pain, 3 questions down the line, chest pain. Chances are that you are not doing very well in that area of the objective, and that is why you are being tested. So somebody will go and come back and say, but Dr. Boni, this was a very easy exam for me, but I failed. Well, because even in the simple things, when you were being tested, you were getting them wrong. And so they kept bringing it back just to see whether you really knew what you were doing or not. Okay, so one candidate would tell me, Dr. Boni, I don't get it. This is the easiest exam I've written since medical school, yet I failed. Why? And that is it. Because number one, a lot of people don't know how to manage their time, and we've talked about that. Number two, a lot of people did not study with the MCC objectives, so they got a bunch of information into their brain, but then they went into the exam and they asked him, why is the exam focusing on this? Because everything the exam is focusing on is in the objectives. And we didn't use the objectives as a study guide. That is my problem. That is why I'm conducting this webinar. I've talked to more than 700 IMGs in the past 6 months. And there are a lot of people who have talked to me one-on-one on Zoom. Every month, I talk to not less than 100 people, one-on-one. And I see the same mistake being made over and over and over again. And that is why I'm really, really focusing on this, because this is very critical. You know, how will you be scored? In the exam, the least score you will get to be 100. The highest score you can get is 400. And to pass the exam, you need to get 226. Okay? The point is, and I've heard a lot of people say, oh, the most important thing is that you pass. No, it's not true. It's not true. It's not true. The residency spots are getting competitive. The practice-ready assessment spots are getting competitive. Anyone who goes around telling IMGs that, yeah, the mark you get does not matter, is not telling the truth. The mark you get matters a lot. And so you realize that, like on our Facebook wall and the rest, people come saying, oh, but I have LMCC, but I have not been able to get into the system. And I go, like, I just ask myself, because that's not why I'm coming to have arguments with you. I just ask myself, that person who says they have LMCC, what was the person scoring the QE1? Because if you are scoring poorly in the QE1, even though you pass with, say, 227, 228, sure, you may occasionally get candidates like that who may get into a practice-ready assessment program or a residency program, but that is very rare. What I'm trying to say is that do everything possible to increase your chances. And what do the statistics say? I went through some statistics from the Medical Council of Canada. In 2021, the least score among the Canadian medical graduates was 229, which was still a pass. That was during the COVID period. The least score among IMGs, of which majority of the candidates here are, was 100. That was there was somebody among the IMG group in 2021 who got the least score. So the person did not do anything in the exam. The mean score, that is the average score among CMGs in 2021 was 268. And this is in the QE1 report sent by the Medical Council of Canada. The mean score among IMGs in 2021 was 232. So look at the difference. Very big. very big. And a lot of IMGs, oh, why are we not getting residency spots? This is one of the reasons why. This is one of the reasons why. Of course, some IMGs are doing well, no doubt about that. But in general, when you compare the results, it's not the best. The pass rate in 2021 for CMGs, that's Canadian medical graduates, was 100%. The pass rate for the IMG group in 2021 was 60.8%.
Yes.
So this is very important, this thing. So if you go through the objectives, every single objective you'll see, if it is a case of like headache, ask yourself, if the headache presents in a child, what is my assessment? What's my diagnosis? What are the red flag things I need to know? What are the causes of headache which is going to kill the patient? How am I going to manage the patient? So if a patient comes in with headache, one of the first diagnoses I should not miss should be meningitis, should be intracranial space occupying lesion, should be cerebral like aneurysmal rupture, things which can kill the patient, subarachnoid hemorrhage, and all those things. I have to make sure that all those ones, I'm very sharp on them because assessment and diagnosis. But which of these assessment and diagnosis carries the highest mark? Then I come down here, 35 plus 5, that is acute. So if I have a patient with headache, I have to know all the causes of headache which can possibly present to the ER. Migraine headache, tension headache, cluster headache. Then I go to the infectious causes, meningitis, encephalitis. Then I go to, structural causes, space occupying lesion. Now I have to ask myself, how do I assess a patient with that kind of headache? How do I diagnose a patient with that kind of headache? That should be my approach. If I have that approach, for example, pelvic pain, if a woman in reproductive ages comes in with pelvic pain, say 28 years, pelvic pain, what diagnosis should I not miss? Yeah. Acute, ectopic pregnancy. Number 2, ovarian torsion. Number 3, acute appendicitis. You see the way we go about it. Then what are other causes of chronic pelvic pain in the patient with who is sexually active and who has the risk of becoming pregnant? Endometriosis, adenomyosis. These fall under chronic. So then with this table alone, I can pick an objective and put various things here. Now, pelvic pain, is there any health promotion and illness prevention thing I need to really focus on? Not really. What about psychosocial aspects? Yes, psychosocial aspects in pelvic pain. What is it? Adenomyosis and endometriosis leading to infertility. Dr. Emmanuel, are you getting me? So according to the exam licensing body, they don't break things into cardiology, respirology. No. They will present something like palpitations. And you have to know that, okay, palpitations will fall under cardiology. But there's an element of palpitations which will also fall under endocrinology. Why? Because if a patient has hyperthyroidism, they can also have palpitations. Now, the other question you asked about how am I going to get my buzzwords and all those things, it's basically repetition and taking note of the various things we talk about. Bye-bye.